Hello, everyone. Welcome to ISGyP Live's Journal Club for January of 2022. The theme this month is Metastasis to GYN Organs and Other Tumors, and I'm your moderator, Natalie Banet. So first, while everyone's joining the meeting, I would like to talk about some upcoming events for ISGyP Live. ISGyP Live has multiple formats, including the upcoming Interesting Case Presentations Conference, which is moderated by Dr. Jennifer Bennett. And that will take place January 26th at 12 noon Eastern US time. This is a trainee and early career pathologist directed format where you'll hear interesting case presentations. I encourage you to join. And also a podcast will broadcast that same day, January 26th at 12 noon US Eastern time. You can access it there at the SoundCloud page. And that will feature Dr. Preetha Ramalingam talking about SMAD4 expression and mucinous lesions of the gynecologic tract, and that's moderated by Dr. Carlos Paraharan. ISGyP Live also wants to hear from you, trainees and early career pathologists. We do have these two trainee focused formats, including the Interesting Case Presentation Conference and the Journal Club. And myself and Dr. Karen Talia and Dr. Jennifer Bennett would love it if you would reach out to us at the email addresses listed there if you or your trainees are interested in presenting. And we do provide mentorship and practice ahead of the events for your trainees and early career folks. So now it's my pleasure to introduce to you our three presenters for today. We have Dr. Kalalilo Coronale, and she is a resident or registrar in anatomic pathology at the Stellenbosch University in Cape Town, South Africa. We also have Dr. Shi.Bai. She is a cytopathology fellow at the University of Massachusetts Chan Medical School, and also a featured GYN and GU fellow at the MGH. And finally, we have Dr. Elizabeth Arslanian. She is the Stuart C. Laughlin Fellow in Women's Pathology at Women and Infants Hospital of Rhode Island. So we're thrilled to have these three presenters with us today. And this month's theme is sort of a miscellaneous theme, so metastatic lesions to the GYN organs and other tumors. So Dr. Kalalilo Coronale will start us off with this article by Taylor and colleagues titled Late Development of Metastatic Ovarian Mucinous Adenocarcinoma from Primary Gallbladder Adenocarcinoma and High-Grade Dysplasia. That's from the International Journal of GYN Pathology. And then Dr. Shi.Bai will present this article by Malpica and colleagues titled Malignant Mesothelioma of the Peritoneum in Women, a Clinical Pathologic Study of 164 Cases from the American Journal of Surgical Pathology in 2021. And then finally, Dr. Elizabeth Arslanian will present this case by Dr. Chappell and colleagues entitled Malignant Peritoneal Mesothelioma, Prognostic Significance of Clinical and Pathologic Parameters and Validation of a Nuclear Grading System in a Multi-Institutional Series of 225 Cases from Modern Pathology in 2021. So the learning objectives of Journal Club are to engage trainees and early career pathologists in gaining scientific knowledge and the ability to critically evaluate literature, to provide opportunities to volunteer as presenters, and to offer mentorship and guidance in the practice of presenting to a global audience, and also to provide up-to-date learning opportunities for practicing pathologists around the globe. This is a summary of the format that the presenters use to prepare their presentations. If you'd like to take a screenshot of it just to follow along with them or just for your reference. So the schedule today, right now I'm giving the introductions. We'll start with Dr. Coronale, then Dr. Bai, and then finally Dr. Arslanian, and then we'll have wrap up and questions at the end. For the questions, for those not familiar with the Zoom webinar format, you can place your questions in the Q&A portion down here at the bottom. So if you click that, you can type in your question. If you see someone else's question that you would like to upvote, you can hit that thumbs up button. Also keep in mind when you exit the meeting, a survey will pop up and we would really appreciate your feedback. We do use that to guide our formatting of future presentations and learning opportunities. So that's all I have. And I will stop sharing. And now I will invite Dr. Coronale to share her screen and begin her presentation.
Hello, everyone. Thank you, Natalie, for the introduction. My name is Khalalelo Koronali, an anatomical pathology registrar from Tygerberg Hospital, Cape Town, South Africa. The paper that I'm presenting is titled Late Development of Metastatic Ovarian Adenocarcinoma from Primary Gallbladder Adenocarcinoma and High-Grade Dysplasia by Jennifer Taylor, Rajiv Shah, Kevin McElven, Paul J. Kelly, and W. Glenn McClegage. It's from the International Journal of Gynecological Pathology, and it was published in 2020.
Dr. Coronali, if you want to go into presenter mode, you can, if you want. Thank you.
Apologies. Yes. Majority of mucinous ovarian carcinomas are mainly metastatic lesions from the gastrointestinal tract or pancreatobiliary region. An admixture of benign, borderline, and malignant areas can be seen in both primary or metastatic mucinous adenocarcinomas. This can pose an especially harder challenge to the practicing pathologists, especially when clinical data provided is limited or is not adequately interrogated. There is no single ancillary study or algorithm to alleviate this dilemma. However, it is imperative that a conclusive diagnosis is reached, and this requires that the pathologist integrates both clinical and histomorphological findings, including ancillary studies. Misdiagnosis may result in detrimental patient outcomes. In this article, we see two case reports which are discussed in great detail. We see two patients who presented with metastatic ovarian disease following antecedent primary gallbladder, high-grade dysplasia, and adenocarcinoma, respectively. The primary gallbladder neoplasm were diagnosed at least 5 years prior to the current presentation with ovarian disease, demonstrating quite a long interval from the first presentation with the primary lesion in the gallbladder to the current presentation with the secondary lesion in the ovaries. Clinical and pathological findings, including a contextual approach that rendered the conclusive diagnosis of metastatic ovarian adenocarcinoma, are discussed in details in this article. The authors give us quite a detailed clinical background and clinical information for both the two cases. In the first case, we see a 68-year-old female who presented with right upper quadrant tenderness and right-sided pulmonary embolism and bilateral complex adnexal masses. No extra ovarian disease was described. Past surgical history revealed cholecystectomy for gallstones 8 years prior, with intraoperative notes revealing bile spillage during surgery. The gallbladder specimen revealed high-grade dysplasia with no evidence of invasion. In the second case, clinical information revealed 59-year-old female who presented with loss of weight and left ovarian disease. Past surgical history as well revealed cholecystectomy for gallbladder, for gallstones 5 years prior to the presentation with the current left ovarian disease. An incidental gallbladder adenocarcinoma was described with subsequent second surgery performed. There was bile spillage during surgery. In both cases, we see also the authors describing pathological findings of these two cases. We'll discuss first the pathological findings from the first case. Macroscopically, the ovaries were enlarged with nodular lesions in the ovarian surface. Microscopically, it was demonstrated that there was mucinous adenocarcinoma with expansile growth pattern and a nodular architecture with surface involvement, focal invasion, and desmoplasia. In some areas, there were overtly malignant glandular elements, while some cystic areas revealed clearly benign areas lined by benign endocervical type mucinous epithelium, demonstrating the so-called paradoxical maturation or maturation phenomena, posing quite a diagnostic challenge The immunophenotype of both ovarian lesions revealed strong CK7 positivity and CDX2 positivity with P53 null mutant staining pattern. The gallbladder specimen demonstrated high-grade dysplasia only with no evidence of invasion. We see a similar phenotype that is described from the ovarian lesion of strong CDX2 positivity and null mutant staining of P53 immunohistochemistry. In the second case, we see the ovarian lesion revealing a metastatic ovarian mucinous adenocarcinoma with an expansile growth pattern, nodular architecture, necrosis, focal invasion, and desmoplasia. Some cystic areas lined by bland mucinous epithelium were also described, again demonstrating an important phenomena of paradoxical maturation. The immunophenotype demonstrated strong CK7 positivity and CDX2 positivity with P53 null mutant staining immunoreactivity. Again, the gallbladder immunophenotype was similar to the left ovarian lesion with strong CDX2 positivity and P53 null mutant staining. The authors continue to discuss in detail and emphasize that metastatic ovarian mucinous adenocarcinomas tend to mimic primary ovarian mucinous neoplasm. They can seem to arise from benign or borderline mucinous tumors of the ovary, especially when they display cystic areas demonstrating bland mucinous epithelium. As the authors describe the maturation phenomena. In both cases, it is highlighted the development of these ovarian metastatic mucinous lesions due to seeding or implantation phenomena during surgery. Case 2 demonstrate an even rarer phenomena of a metastatic adenocarcinoma developing from a non-invasive precursor lesion of the gallbladder. According to the authors, this has not been described anywhere. Only a similar presentation have been discussed with tuber-ovarian mucinous adenocarcinomas, in which an in situ adenocarcinoma of the cervix led to a tuber-ovarian metastatic adenocarcinoma. The discussion further details certain morphological clues that, when interpreted in the right context, may guide and lead one to diagnose metastatic over a primary ovarian lesion. Some of them being the nodularity, surface involvement, lymphovascular invasion, etc., etc. The authors offers an important discussion about the role and interpretation of immunohistochemistry. They emphasize that generally there is an immunophenotypic overlap between ovarian and pancreatobiliary adenocarcinomas. However, certain immunoprofiles can guide on the diagnosis of metastatic pancreatobiliary mucinous adenocarcinoma over primary mucinous adenocarcinoma. One of them is SMAD4 loss of expression, in which it offers potential to be a valuable marker in deciphering the two lesions of primary versus metastatic. Largely invasive adenocarcinomas of the gallbladder or pancreatobiliary region tend to demonstrate P53 mutant type staining, while primary ovarian mucinous adenocarcinoma exhibit diffuse strong positive mutant P53 staining pattern. The authors demonstrate that with their experience, PAX8 is quite invariable or unreliable, in the sense that it tends to be negative or weakly negative, while it has been described that it's positive in up to 65% of ovarian mucinous neoplasm. They express that CK7 positivity, CK20 immunoprofile can be encountered in both ovarian and gallbladder neoplasm. This is quite a great discussion in which we see a conceptual approach when encountering ovarian mucinous neoplasm, both primary and metastatic, in which one has to pause and revisit important parameters in order to arrive at a conclusive diagnosis. This article also demonstrates limitation of immunohistochemistry in distinguishing ovarian miscellaneous adenocarcinomas of primary or metastatic origin. It illustrates the importance of clinical pathological correlation in arriving at a conclusive diagnosis, which is quite important for patient management. This is quite an important article. It has great discussion points. However, there are certain areas in which the author could have added to the discussion, and one of them is to recognize that some laboratories are not as well resourced and may not have access to a good panel of immunohistochemistry or ancillary diagnostic tools. The example is the availability of SMART4 immunohistochemistry, in which it is been shown that loss of expression can point towards the diagnosis of pancreatobiliary adenocarcinomas. It would have been of great addition to the discussion to demonstrate, to attempt to demonstrate a diagnostic algorithm, especially to help the young or the new pathologist when encountering ovarian miscellaneous neoplasm, with consideration of other primary sites other than the pancreatobiliary region. As well, it would have been a great discussion also to discuss a situation in which pancreatobiliary tissue from a teratoma may give rise to a miscellaneous neoplasm, in which immunohistochemical profile may be similar to primary pancreatobiliary region or region. Some of the important applications that we learn from this article is that it is imperative, it's important for one to pause and reevaluate prior clinical history when faced with a miscellaneous neoplasm of the ovary. It's important to review prior histopathology to correlate with new onset lesions that don't have any other clinical data that can guide to arrive at a diagnosis. I thank you for affording me this opportunity to present in the journal club.
Thank you, Dr. Coronale. What is that a picture of?
It's the Makadi pens. We see a lot of zebras. They're drinking at the salt pens in Makadi. It's usually dry most part of the year, but during the winter season, there is water and you can see them come to the drinking hole.
That's amazing. Thank you for sharing. And good job on the presentation. I picked this article specifically, or offered it up as a choice because I think it's such an important thing to think about, and you don't hear a lot about gallbladder. So when it comes to GYN organs, so I'm glad that you were able to present that. You can go ahead and stop sharing your screen, and if anyone has any questions, you can put them into Q&A, and we'll do those at the end. And now, Dr. Bai, you can go ahead and share your screen and turn on your camera.
Okay, share my screen. Okay. All right, can you see it well?
Yes, it looks great.
Yeah, okay. Thank you, Dr. Banet, for the introduction and this opportunity to present in the journal club. My name is Shi. I'm the cytopathology fellow from University of Massachusetts Chan Medical School. Today, I'm going to present this paper titled as Malignant Mesothelioma of the Peritoneum in Women, a clinical pathologic study of 164 cases. This is an article published recently in American Journal of Surgical Pathology by a group of authors from the University of Texas MD Anderson Cancer Center. A brief background and study design. Peritoneal mesothelioma is an uncommon neoplasm, estimated incidence of 0.1 per 100,000 women. In compared to the pleural mesothelioma, it is more often occur in younger patients and commonly linked to asbestos exposure. And due to the rarity of this entity, it is less well characterized in compared to the pleural counterpart. So the objective of this article is to retrospectively study a large number of cases, including clinical information, pathologic findings, treatment, and follow-up. They also studied prognostic factors associated with the disease. Method used in this article, including as follow. All cases were retrieved from Department of Pathology at MD Anderson Cancer Center over 42 years. They reviewed the histology and clinical information. Immunohistochemical stains were performed or were provided by contributing pathologists. Electron microscopy was used to confirm the diagnosis in 11 cases, and fluorescence in situ hybridization FISH was used to detect CDKN2A homozygous deletion in 1 case. Kaplan-Meier curves were used for overall survival. Cox regression was used to perform multivariate analysis. So here are the results session, which include clinical feature, pathologic findings, IHC results, initial diagnosis, treatment and follow-up, survival data, and statistic analysis. I'm going to present some of these results. Sorry. So this is a nice table summarizing key clinical features of this study. The median age for this study is 49 years old. The most common clinical presentation is associated with peritoneal disease, for example, abdominal pain, distension. About 27% of the patients present with ascites, and 2 of them present with mucinous ascites. Majority of the patient had multiple site involvement. Lymph node involvement represent like 8% of the patient. Asbestos exposure was documented in 9% of the patient, either from direct exposure or indirect exposure. The treatment is variable. Majority of patients receive treatment of chemotherapy, cytoreduction surgery, and hyperthermic intraperitoneal chemotherapy, also called HIPEC. Outcome is available in 120 patients. 60% of them were alive with or without disease. 35% of the patients die of disease. The median overall survival in this study is 75 months. So the paper also nicely documents the personal history, and they found about 31% of their patients had a personal history of other neoplasm. This is a table summarizing the neoplasm that occur in patients with peritoneal mesothelioma. Most common being the ovarian neoplasm, including both benign and malignant tumors, and include both epithelium and sex chorostroma tumor. The next common being the breast cancer, followed by endometrial carcinoma. There are also other tumors that listed in this chart as well. So the paper also document detailed information of family history, and they found approaching to 70% of the patient had a family history of other neoplasm. And this is a table nicely listed the tumors that occur in first-degree relatives, second-degree relatives, and third-degree relatives. The family history is highly variable. However, most tumors were within the spectrum of syndromes, such as BAP1 tumor predisposition syndrome and Lynch syndrome. Due to the respective nature of the study, genetic testing is limited to only 5 patients. They are BAP1 germline mutation, type 2 pneumofibromatosis, Lynch syndrome, Michael-Albright syndromes, and 1 patient tested with no BAP1 or TP53 mutation. Moving on to microscopic feature, epithelioid type is most common morphology types that are seen in 80% of their cases. It's featured by this typical papillae, has a core of connective tissue lined by the single layer of neoplastic cells. About 20% of their cases present a biphasis type morphology featured by this epithelioid morphology mixed with the spindle sarcomatoid cells. None of their cases shows pure sarcomatoid morphology. Architectural pattern can also be a variable. This is a figure nicely presented the different architectural patterns that can be seen in peritoneal mesothelioma. Figure A shows papillary patterns without connective tissue core mimic a serous carcinoma. In figure B shows solid growing patterns, in this particular case, composed of predominantly deciduous cells featured by these plumped epithelial cells with dense eosinophilic cytoplasm. It can also have this tubular glandular growing patterns as shown in figure C. Sometimes the tubule can be dilated and mimic a solitary fibrous tumor as shown in D. The cells can forming a cluster or singly infiltrating the underlying tissues. And also occasionally it can show cystic patterns that mimic a mesothelial inclusion cyst. So for the epithelioid type pattern, there's a different cell morphology can be seen as well. In figure A, this showing a Signal cell morphology that can mimic a Signal cell carcinoma. It can also show this multinucleated cells. Now, some of their cases have clear cell morphology that can mimic a clear cell carcinoma. In this particular case, nuclear and cytoplasmic stain for creatinine confirmed the diagnosis of mesothelioma. We all know immunohistochemical studies plays important role in supporting diagnosis of mesothelioma. International Mesothelioma Interest Group suggests using a panel of marker composed of at least a carcinoma marker and at least mesothelioma marker to support the diagnosis. And this is a table nicely summarized the most commonly expressed marker and some other markers that can be seen in mesothelioma as well. The first 5 being the most common expressed marker, they are creatinine, keratin 5/6, D240, thrombomodulin, and WT1. Some diagnostic pick for MARK31, P4, which we commonly use to support diagnosis of carcinoma, can focal and patchy positive in 14 and 16% of their cases. PAX8 is available in 40 cases, and about 22% of their cases show patchy or diffuse positivity as well. So moving on to statistic analysis, the paper used univariate and multivariate analysis to study the following variables. Particularly in the multivariate study, they found absent of surgery, nuclear grade 3, predominantly decidual patterns are associated with worse prognosis. So in the discussion session, the author mentioned this is a rare entity. The age range, clinical and presenting features are largely similar to previous studies. About 1/3 of their patients had additional personal tumor history, and about 70% of their patients had family history of other malignancy. Asbestos exposure reported in only 9% of the patient. Most common morphology is epithelioid type. Their variable architectural patterns, most common being papillary, solid, tubule-glandular patterns. There are some atypical clinical and pathologic features that can lead to misdiagnosis. For example, patient may occasionally only presented as cervical lymphadenopathy, and patient may present at mucinous ascites, signal cell morphology that can mimic a carcinoma. Clear cell morphology can mimic clear cell carcinoma. There are also cases demonstrate well-differentiated papillary mesothelioma-like or adhesion-like error that can lead to misdiagnosis of a benign mesothelial lesion. WT1 and creatinine are most frequent positive marker, and MARK31, P4, PAX8 can be positive as well. So the author mentioned in about half of their referring cases, or misdiagnosed initially, and they have a detailed discussion in this differential diagnostic entities, which I summarize in this table. For fluoride reactive mesothelial hyperplasia and well-differentiated papillary mesothelioma, also recently called well-differentiated papillary mesothelial tumor, are the benign mesothelial lesion. It usually limited to peritoneal surface, usually small rather than disseminated. And there are no invasion into the underlying tissue. And we can use BAP1 and CDKN2A to support the diagnosis, but not all the malignant mesothelioma will show the BAP1 loss or CDKN2A loss. In that challenging cases, we can further understand for genetic profiling. Serous borderline tumor with implant can enter into differential diagnosis. The papillary and serous borderline tumor usually show tufting and cell detachment, but malignant mesothelioma can show cell stratification and detachment as well. And the author suggests using a panel listed here and also FISH to support a diagnosis. Metastatic carcinoma can be a challenging differential diagnosis. History of previous or concurrent malignancy can be helpful, but can also be misleading as well. So they also suggest using multiple keratin stains with additional markers, including mesothelial markers and other site-specific markers to support the diagnosis. Clear cell carcinoma can occur occasionally in peritoneum, and using the HNF1B, Napsin A, and absence of mesothelial markers can be helpful as well. The strength of this article, it is a large study cohort, and is so far is considered one of the largest studies for the peritoneal mesothelioma. It comprehensively reviews the clinical data, clinical presentation, pathologic finding, treatment follow-up, and etc. And they also further study prognostic factors of this disease, which is very helpful. Areas for improvement. First of all, the paper does not have a control for treatment. However, it does demonstrate the overall improvement of survival in patients treated with cytoreduction surgery and HIPAC. It also did not test for new or relatively new antibodies such as BAP1, Claudin-4, and MTAP. It also did not test for molecular profiling. Applications from this paper. The paper showed a strong family history of other malignancies, some of which could be syndromic. So more studies needed to examine whether peritoneal mesothelioma is within the spectrum of hereditary tumor syndrome. Also, familiarity with the clinical features, morphologic spectrum, and IHC profile can assist in establishing the correct diagnosis. For the histologic features that associate with worse prognosis, for example, predominant deciduoid cells and higher nuclear grade, can be emphasized in the report for possible treatment guidance. So that's it. Thank you. I'm happy to take questions.
Thank you, Dr. Bai. We don't have any questions in the Q&A now, but we'll have some at the end. I have some for you. I think that was a really good presentation. Like we said, that your article and Dr. Arslanian's articles are both really a lot of data, and I think you did a good job condensing it down. So thank you so much for that. We'll go ahead and ask Dr. Arslanian to share her screen, and we'll do her presentation now.
Okay, can you see it properly now? Is it working?
Yes.
Okay, perfect. Great.
It's a little bit hard to hear you, so I know you have your headphones in, but just.
Is it okay right now?
Yep, it's great. Thank you.
Okay, perfect. All right, so the article I'm presenting is Malignant Peritoneal Mesothelioma, Prognostic Significance of Clinical and Pathologic Parameters and Validation of a Nuclear Grading System in a multi-institutional series of 225 cases. As you can see, 20 authors participated in this work. The senior author is affiliated with the University of Chicago, and this article was published in early 2021 in Modern Pathology. So I'm going to do a very brief introduction on mesothelioma because I know probably most of you just listened to the previous presentation. So as you know, it's a rare malignancy of serosal linings. It occurs in the peritoneum and in other sites, but in the peritoneum, it tends to occur in younger patients, more commonly in female patients. It is less commonly associated with asbestos exposure, and it is more frequently of the epithelioid histologic subtype. Modern therapy includes cytoreduction surgery and intraperitoneal chemotherapy, and this has tremendously helped improving outcome However, the disease remains unfortunately incurable. So the authors here were mainly looking at prognosis. So they had two main questions. Their first question was, what is the prognostic significance of 21 clinical and pathologic parameters in peritoneal mesothelioma? And their second question was, could the composite nuclear grading system that was developed for plural epithelial mesothelioma also have prognostic value in peritoneal epithelial mesothelioma? To do so, they retrospectively gathered 225 cases of peritoneal mesothelioma from 11 different centers located in 6 different countries. Submitting pathologists sent a couple of H&E slides for central diagnostic review, and all of the samples were taken from patients who were status pre-chemotherapy. Submitting pathologists also sent unstained slides so that immunohistochemistry studies for BAP1 and Ki-67 could be performed centrally. For those of you who might not be familiar with the immunostained BAP1, it can be used when we're dealing with a mesothelial proliferation and when we're wondering, is this malignant or is this benign? If there is loss of nuclear expression, then it supports a diagnosis of malignancy. If it's retained, it doesn't really help you. The authors excluded cases of well-differentiated papillary mesothelioma, which some of you might know as well-differentiated papillary tumor. And they also excluded benign multicystic mesothelioma, which is the peritoneal inclusion cyst. And these were not included in the 225 case count. So these 225 cases were divided into 2 subcohorts based on the year of diagnosis. So cases diagnosed in the last 2 decades were analyzed separately than cases diagnosed before 2000. The reason behind that is that the authors were anticipating some differences in pathobiology and in clinical behavior. Otherwise, the composite nuclear grading system that was inspired from the system in the Plura, this is basically the sum of 2 scores. So we're looking at a pleomorphism score and at a mitotic activity score. The pleomorphism score is based on the degree of atypia, and the mitotic activity score is the number of mitoses per 10 high power fields. Now, the sum of these 2 will yield a composite grade 1, 2, or 3. The authors unfortunately didn't provide much more detail on how these scores are applied. However, they did give the reference to the article in the Plura where it was studied. And in that article, they do mention that for evaluating pleomorphism, you have to look at the area with the highest degree of atypia, provided that this area represents at least 5% of tumor volume. And for mitoses, you look at a hotspot. Listed here, the statistical methods. I'm not going to read that to you. It's just for your reference. Sorry. So this is the list of the 21 parameters they were looking at for potential prognostic significance. So we have different categories here: clinical parameters, surgical parameters, radiographic, morphologic, and outcome parameters. We're pathologists, so let's look at the morphologic parameters. First of all, there's the histologic subtype. So we have 3 subtypes here: epithelioid, biphasic, and sarcomatoid. Unfortunately, it was not specified in the article if biphasic was merely a combination of epithelioid and sarcomatoid, or if they were requiring a minimum cutoff. Let's say, I don't know, did we need to have at least 10% of tumor volume being epithelioid and 10% sarcomatoid? It was not said. The other parameters, morphologic parameters with potential prognostic significance, were nuclear pleomorphism, mitotic rate, necrosis, and architectural patterns. So the architectural patterns were evaluated only in epithelioid tumors, and they considered 3 patterns for purposes of statistical analysis. First, a predominantly solid growth, predominantly tubulopapillary growth, and a tumor with any degree of micropapillary growth. So the composite nuclear grade, the lower it is, the longer are both the overall survival and also the disease-free survival. If we look at the subcohort of patients diagnosed in the last 2 decades compared with patients diagnosed before 2000, those patients tend to be younger, more often female. We're seeing lower proportions of biphasic and sarcomatoid histotypes, and we're seeing lower proportions of cases with necrosis. Otherwise, several of the 21 parameters were associated with longer overall survival, and this is what we're looking at on this slide. So if we look at the whole cohort, the 225 cases, both epithelioid histologic subtype and a diagnosis after 2000 were associated with longer overall survival. Otherwise, if we're looking only at cases diagnosed after 2000, then we also have a younger age at diagnosis. So here, 60 years old is the cutoff. That was the median age of the cohort. A good ECOG performance status. This is a clinical score which basically evaluates the patient's functional capacity or capability for self-care. The absence of nodal metastasis by radiology, also a good prognostic factor. Patients who receive cytoreduction surgery, patients who receive intraperitoneal chemotherapy or HIPEC, and patients with a low peritoneal carcinomatosis index less than 27. So this is a score that goes from 0 to 39. It's assigned by the surgeon during cytoreduction surgery, and it's basically an assessment of the presence, size, and extent of tumor implants. The absence of tumor necrosis was also associated with longer overall survival. Now, if we're still looking at cases diagnosed after 2000, but only cases of the epithelioid subtype, all of these are still true, except that tumor necrosis is not independently associated with overall survival in that group on multivariate analysis. Plus, we're adding extra factors that are also associated with longer overall survival in that subgroup. So these factors are female sex, a predominantly tubulo-papillary architecture, lower nuclear pleomorphism, a low mitotic index, a lower composite nuclear grade, and a low Ki-67 index. And the bottom figure here is to show you the overall, the survival curve. So here, vertical axis is overall survival probability, and the horizontal axis is months after diagnosis. And they're comparing the survival curves for biphasic peritoneal mesothelioma, sarcomatoid versus grade 3 epithelioid versus grade 2 epithelioid versus grade 1 epithelioid. But we're only seeing 4 curves here because that curve here is actually the biphasic and the grade 3 epithelioid curves that are largely overlapping. Just a second. So this is to exemplify the composite nuclear grading system. So about half the cases were grade 1. They had cases of grade 2, and a minority of cases were grade 3. And we are seeing increasing degrees of pleomorphism and more mitoses as the grade increases. This table here, I just want you to look at BAP1 because we've already discussed the other parameters here, but basically they were wondering if BAP1 had a prognostic impact. So whether we're looking at all mesotheliomas diagnosed after 2000 or only at epithelioid mesotheliomas diagnosed after 2000, whether BAP1 is retained or lost, we're not seeing differences in prognosis. So a couple of discussion points that the authors brought up. First of all, if we look at patients diagnosed in the last 2 decades, they do have improved outcome. Part of the explanation is that a lot of these patients have access to modern therapy. However, if we look at patients in that subgroup who do not have modern therapy, they still do better than patients diagnosed before 2000. And the explanation the authors provided is that we're seeing decreasing proportions of poor prognostic factors like non-epithelioid tumors, asbestos-related tumors, and diagnoses in male and in older patients. Otherwise, the composite nuclear grading system has been shown to be prognostically informative. So among the 21 clinical and pathologic parameters that we're looking at, this is the only one that was independently associated with both overall and disease-free survival. And there was another study on peritoneal mesothelioma where they were looking at a similar nuclear grading system. It was a 2-tiered system, however, and in that study it was also associated with overall survival. Perhaps the only unexpected finding in that study was that necrosis on multivariate analysis was not independently associated with overall survival in peritoneal epithelioid mesothelioma. It was associated with overall survival in the larger group of all cases diagnosed after 2000. And this also contrasts with what we know in pleural epithelioid mesothelioma, where necrosis is associated with overall survival. So unfortunately, the authors did not provide much of an explanation for this, and I have to agree that it's quite puzzling, to be honest. Otherwise, the authors listed a couple of study limitations. I only selected a couple of them. So they mentioned that when assessing pleomorphism or mitotic index, the inter-observer agreement is at best fair. So of course, this will have a negative impact on nuclear grading. The morphologic analyses, because they purposely selected only cases that were status pre-chemotherapy, where, well, of course, they're not validated for post-treatment material. So the results might not apply to post-treatment cases that we see in our practices. Overall, it's of course a very strong study, especially in terms of validity. It's a very large cohort, cases from multiple institutions, multiple countries, also cases that were more recent or analyzed separately. So the results are likely applicable to what we see in our practices. The authors also did an extensive job reviewing centrally the cases and also performing IHC centrally, which eliminated some bias and ensured consistency in application of diagnostic criteria. And also the grading system that they validated is not only prognostically significant, it is also very easily applicable. In terms of areas for improvement, I have to admit it was a little bit more difficult to identify things. I think it was a very good paper, but I would have liked to see maybe a little more detail for some of the definitions. As I mentioned earlier, for instance, biphasic histologic subtype, was it merely the presence of epithelioid and sarcomatoid, or was there a cutoff? Or again, for the nuclear grading system, I would have liked to have all the detail for how to apply this nuclear grading system without having to look at another paper. And although they did do central diagnostic review and IHC, one of the submitting institutions did not send their cases for central review, so it would have been better if all the centers had done so. So what are the take-home messages here? The composite nuclear grading system, certainly, and it can be implemented in most centers, in my opinion, because you just need a pathologist, microscope, and an HME slide. You don't even need IHC, no molecular studies, nothing fancy. And also because they've showed that there are differences in prognosis between, for instance, your grade 1, 2, and 3 epithelioid. Well, maybe eventually some clinical studies could be performed to see if these cases should be managed differently. The other morphologic parameters that were associated with prognosis are also all easy to assess and report. For instance, histologic subtype, architecture, pleomorphism, mitotic index, nuclear grade. That's parameters that any pathologist can put in their report. And this leads me to thinking, how come we don't have a synoptic report for peritoneal mesothelioma? I know it is very rare. It's even rarer than pleural mesothelioma, but pleural mesothelioma has its own CAP cancer protocol. Other peritoneal diseases have their protocol, the ovarian and peritoneum protocol. So maybe because at this point, we do know a lot about, well, we do know now stuff about, the morphologic parameters that have some prognostic impact. Maybe it could be time to consider getting a synoptic report for that disease. So thank you very much. That's it for me.
Great. Thank you, Dr. Arslanian. It's a complicated paper. You all can all turn on your cameras now. We're going to have the question session, so we can hear from everyone. There was one question from the audience that says, what were the EM findings done to support the peritoneal mesothelial findings? I'm guessing they're asking, did they do EM? Dr. Bai, I think your study was the only one. Yeah.
Yeah, that's a really good question. Actually, when I read the paper, I do have the same question. The paper itself didn't mention exactly what finding in the EM, but I actually look for myself. I think this is a long microvilli. And that's more support of a mesothelial lineage rather than a carcinoma. You will see, for example, like a keratin. I think it's a filament that's in the EM. So I think I didn't know on that, but just briefly search. Might be some of the clue.
Yeah, I think so. And I think because your study or the studies had some older cases in them, it's not surprising that some of the cases did have EM. I don't think in 2022 we're using EM to diagnose mesothelioma as much. Maybe some places still do, but I think IHC has kind of supplanted that. But definitely there were 11, I think there were 11 cases in your study where they just say it was confirmatory. And like you said, they don't really tell you what that meant. But for the person asking, it was done in some cases. And then I guess this sort of the theme this month is the idea of sort of gynecologic primaries involving sort of the gynecologic distribution of organs and how we all need to sort of keep that in mind. And Dr. Bai and I were talking about how she's going to be a cytopathologist and how cytopathologists sometimes kind of have this in the front of our minds because we're always thinking about mesothelioma in other sort of plural, the pleural space and other mesothelial line spaces. So I guess we'll just start also with Dr. Coronale, because your study also addresses this huge question of mucinous lesions of the ovary. You were mentioning how you wish there had been a sort of more thorough review of an algorithm that you should follow. And Dr. McCluggage, of course, is very prolific and he has written papers with algorithms. But in one of his papers recently, he commented that the pendulum has kind of swung, right? Maybe we started off thinking that a lot of mucinous tumors of the ovary, were of the ovary, but it turns out they weren't, right? They were metastatic lesions from places like the appendix. And now we know that some, mucinous tumors of the ovary are primary, but a lot of GYN pathologists even comment that you should rule out a metastatic focus because, like you say, there aren't really good immunomarkers for some of these upper GI primaries. So in your daily practice, since you're in training right now, what was your biggest takeaway point from this article for you? What was the thing you learned?
Thank you, Natalie. One of the biggest takeaway point is in my setting where I'll be practicing in Botswana, we see quite advanced stage disease. Mm-hmm. So in this case, we'll be seeing a lot of metastatic lesions, and it will be important for me to try and address and see where the primary lesion is. It will be quite important for the patient management and outcome.
Mm-hmm. And is that something that they do at frozen section? So you would have communication with the surgeon there, or are they evaluating any of those tumors that way?
We're not quite there we don't have intraoperative diagnostic abilities. We're quite not there yet.
Okay.
So we won't have that ability, unfortunately, but hopefully. Yeah,
we'll get there. Yeah, because that can be a good time to have a conversation and say, do you see anything else going on? But, imaging certainly is another way that you can do that, especially with advanced disease patients. So that's a good point. Yeah. Were you finished making your point?
Yes. Thank you.
Okay,
yes.
Thank you so much. And what about you, Dr. Bai? What was your biggest takeaway point from your article?
Well, the main take point, I learned a lot from this article. This is a rare entity. We rarely encounter that in our daily practice. Good things to learn, the clinical point, the presentation, and also pathologic features. The spectrum of morphology is extremely helpful. When I encounter such a thing like, morphology, I may remind myself, add a mesothelial marker. Could this be a mesothelioma? So that's the main take point. And, the clear cell, the signature cell can also be seen, which I learned a lot from it.
Yeah. It's mesothelioma is like the great masquerader, right? It can sort of almost like a melanoma. It can look like just about anything. And Dr. Arslanian, I was going to get to you, but someone also asked a question. Oh, okay. They ask specifically about the nuclear grading system for pleural mesothelioma. Is it well accepted, and do we know if it's reproducible? I think I know the answer. Go ahead. Yeah.
Okay. So in the pleura, I believe, if you look at the pleural mesothelioma cap cancer protocol, it is an element, but I think it's an optional data element. I was not aware of that, and I had extensively reviewed the cap cancer protocols for my licensing exams and stuff like that, and I don't remember anyone ever bringing this up. So I don't know how widely used it is. And the center where I was trained, we did see cases, but no one ever really mentioned that to me before. So I'm not sure how widely accepted it is, but it is an optional data element at this point in the pleural cap cancer protocol. And in terms of reproducibility, well, the authors did mention, I don't know about the pleura, but in my article, they mentioned that, if we break it down and if we look at pleomorphism or if we look at mitoses, there is the inter-observer agreement is at best fair. So of course, what is the inter-observer agreement for the whole grading system, it might not be, excellent. In that article, there were 2 pathologists involved in reviewing the slides and performing the grading. I don't know if they looked at what their agreement was or if they just separately looked at different cases.
Yeah, you and I were talking when we practiced about how much we loved that list that they put at the end about caveats and limitations, because it's so perfect. They just lay it all out, and they specifically say, like you said, it was at best fair. And there is a study from Human Pathology in 2017 that they referenced to talk about reproducibility of that. So if the person who asked that question wants to go look that up, because I did not read that article. And then Dr. Arslanian, if you just want to round this out here, we have about 5 minutes left. If you just want to tell us what your biggest takeaway point was from this article for you. It's your...
I guess I hadn't realized before looking at that article the range of different clinical behaviors that you can see from mesothelioma. In my mind, it was just, dismal prognosis and that's it. But if you look at, for instance, what they mentioned in that article, even when patients get treatment, you do see survival in between 31 months and 92 months. So there's huge differences. So the fact that they were able to list all of these morphologic parameters that had, prognostic impact, I guess it's valid to have these points, because it's not just a patient's going to survive 2 months more than someone else. It's, you see big differences in the clinical course. And
and how different peritoneal mesothelioma can be from sort of the picture in our head we have of mesothelioma of the asbestos exposure and cigarette smoking and males and things like that. This is like pretty different presentation. So okay, well, if that's all the questions we have from the audience, I want to thank all 3 of you. Thank you so much. I think you all did a wonderful job. Great way to start 2022. I know we have a lot of sore throats and coughing on the panel today, so I hope everyone feels better. And thank you all so much, and thank you to the audience. And on your way out, don't forget to take the survey. Okay, thank you so much.